Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today we have a men's talk organized for you. It's prostate, ED, and your bladder. What is the connection? You will be watching us today on our YouTube channel. I do want to just put up, I do have a viewer discretion advised on this particular topic for you. So that is running across the screen for you as well right now. We're going to go ahead. I want to introduce to you Samantha Johnson. She is with our TMC Outpatient Therapies, and it does all things to do with the pelvic floor. You'll be able to see her again in May during Women's Health Month as well, and she'll be discussing women's issues. So welcome, Samantha.
Thank you.
So I'll go ahead and put your PowerPoint up for you, and then you can go ahead and get started.
All righty. So
the print is so small that you can hardly read it.
Yeah, so I was telling Jennifer or Maya or somebody if we have any issues with the print being too small. I don't know if there's a way that we can get an email so that people can send an email and ask for it to be printed, to get like a virtual copy of it, but we'll straighten that out afterwards. But I'll have it up on here, so hopefully you just have to take some written notes for now. Again, my name is Samantha Johnson. I'm a physical therapist. I've been in Tucson for about almost 4 years now. And I've been mostly treating pelvic floor since then. So hopefully I've got some knowledge for you. Today, we're going to be talking about prostate, erectile dysfunction, and your pelvic floor because they're all interconnected. I wanted to start off with some fun facts. Personally, I just always think it's interesting to see how the history of health has progressed. Prior to about 1519, it was thought that erections were caused by spirits and air going into the penis. So we've come a little way since then. It wasn't until the 1900s and when we became aware that the pelvic floor was connected to all of this. You can kind of see the progression as far as learning about prostatectomies and then the connection with the pelvic floor exercises. I think that was developed first in women. And then it wasn't until 1996 that we actually developed a scientific-based way of assessing the pelvic floor muscles for men. So we're a little bit behind on that, but it's a rapidly growing field right now, and we're learning a lot. There's a lot of research. So hopefully we get some more good information in the future. So just wanted to start out with, what is the prostate? I think most people probably have a general idea of what it is, but based on my conversations with patients, often it's a little bit of a nebulous concept as to exactly what the role of it is. It's situated right below your bladder. So hopefully this picture is big enough that you guys can all see it. Some of the functions of the prostate are to produce fluid that goes into the semen, and actually it's kind of a fibromuscular structure, so it helps with ejaculation to a degree. In young adults, it's about the size of a walnut. And then around 30 to 50 is when it starts to grow. What's interesting about the prostate is not only does it grow outwards, it also grows inwards, which is significant for my online viewers. It doesn't just grow outwards, it also grows inwards. And that's significant because your urethra runs straight through it. So if it's growing inwards, it's closing down on that urethra, which is what gives us those common issues of the obstruction, difficulty urinating, hard to get it to empty, start and stop, and that sort of thing. Other common issues that this is just the regular growth we think about is called benign hypertrophy, and that's different from a cancer, obviously. Also, a common complaint that I see is prostatitis, which is pain related to the prostate. We won't go into detail on that today. That's a little bit nebulous as well. So the prostate is kind of interesting in all of the different ways that it can impact the pelvic floor. I want to direct you to kind of over on the left side of the screen for a moment. That difficulty emptying the bladder, feeling like you're not fully empty, the hesitant or intermittent flow are the first symptoms that we start to see with that. And like we just talked about, that's because the prostate is growing inwards and it's blocking off the urethra, making it hard to eliminate. Because it's difficult to actually get the urine out because you've got this structure closing down on the urethra and creating a stricture or a closing. Your pelvic floor muscles, which are your muscles of bowel, bladder, and sexual function, they kind of go on vacation because they don't really need to work anymore. The prostate is doing their job as far as keeping the urine from coming out at times you don't want it to. That's great, except for then the muscles get deconditioned. If I go on vacation and I don't work out for several years, I can't go back to doing what I used to be able to do. So the other thing that happens with that is our pelvic floor muscles are responsible for the erections. We just saw that on the fun facts. If those muscles are not strong enough, they can't entrap the blood in the penis enough to be able to maintain an erection, which is why another symptom that goes along with the prostate dysfunction is difficulty having an erection and maintaining an erection, or just not sufficient of an erection. Prostatectomies are the surgeries that we do to relieve the dysfunction caused by the prostate. Now, I put the radical prostatectomy on top because that's kind of the big heavy hitter surgery that can be a little bit more problematic. This is the one that more often they're doing because of cancer. The whole structure needs to be removed. Often they're doing what's called nerve sparing radical prostatectomies, where they try not to take the nerves out that go to the prostate and around the prostate. It has intermittent success. More often than not, it's very successful, but it can still have some complications that we'll talk about in a minute. It can be done two ways. They're either cutting through your abdomen through the peritoneum that way, or they're going through your perineum. Your perineum is the space around the base of the genitals, the base of the penis, the scrotum, and around the anus. The transurethral resection of the prostate, or the TURP, is what's more often done with that BPH, the benign hypertrophy of the prostate. And essentially what they're just going in is they're removing where the prostate has closed down in the middle, so that it's easier to get the urine to come out without having to work quite as hard at it. It's typically done through a scope through the urethra. As you can guess or have experienced or maybe know from word of mouth, complications with that are urinary incontinence. With the TURP that we just talked about, where they go in and they remove the middle, usually that's resolved within about a year, but the research is actually not really good with telling us how many people are resolved within a year or how often it is completely resolved to have that incontinence. Part of that is because of the pelvic floor weakness, like we just talked about. The pelvic floor went on vacation because the prostate was doing its job for it. It doesn't just come back online because we've removed the blockage of the prostate. We've got to get it back in shape. Also with that, the prostate is really close to the internal urethral sphincter. We've got two sphincters. The internal one is the one that your brain controls without you knowing about it. It actually sits right at the base of the bladder on the top of the prostate. So as you can imagine, that sphincter can get impacted with the surgery, even when they're doing a really good job with it. Another thing that is a common complaint if that sphincter is compromised is called retrograde ejaculation, or a dry ejaculation, where the ejaculate actually goes back up towards the bladder instead of out through the end of the penis. Another factor to consider, we talked about the nerve sparing for a second there. The proximity of the prostate to the sympathetic nerve plexus and the parasympathetic nerve plexus that can contribute to difficulties with erection. Now, sorry, I'm trying to keep up with my own papers here. Now, there's two different plexuses here. I wanted to clarify that your parasympathetic nerves are your rest and digest nerves. These are the ones that are they're working when everything's safe, there's no danger, and we're in a relaxed state. Your sympathetic nerves are your fight or flight nerves. So it seems a little counterintuitive that those two things are both working at the same time, but they actually work together. Your parasympathetic nerves are what allow the blood to flow into your penis. They induce the release of something called nitric oxide, which is what allows those vessels in your penis to vasodilate so that the blood can go into them and increase the blood flow. Your sympathetic nervous system then comes into play more towards the end of the sexual interaction, where you're actually having ejaculation. It helps with the contractions of the vas deferens, which is what brings the seminal fluid up towards the penis from the testes, and the prostate itself to help move the semen into the urethra. So if you can imagine, we're kind of starting at the top of everything with this. I know the picture's a little bit of a misnomer there. But that's kind of what's going on more higher up as far as the chain goes with erections. And then we have the muscles themselves. So the two muscles that are primarily involved in helping with ejaculation are one called your bulbospongiosus and your ischiocavernosus, or spongiosis. It depends on which textbook you're reading. It's interesting, these muscles are all also present in women. They have slightly different anatomic alignments, but they are there. These are your muscles that are helping with getting the semen out of the penis during an ejaculation. Moving on to the erectile dysfunction, there are 3 recognized types of erectile dysfunction. Organic erectile dysfunction is going to have more of a physiologic cause to it, whether it's a vascular issue or there's something with the nerves, like can happen after a prostate surgery. The hormones themselves, if there's not enough testosterone, can have an impact on things. Also the smooth muscles, because the vessels in the penis have muscles in them themselves. Another thing that can come into it is what's going on in your head with the psychogenic. If there's a lot of emotional distress, your system might decide that now's not the time to procreate. Maybe, I'm having a fight with my significant other, and that's making it hard to get in the mood for things. Another thing clinically that I see a lot is that if your partner is having a lot of pain with intercourse or with pelvic pain and they're working through that, sometimes men can then, or the male partner or the person with penis can then have issues with getting an erection because of kind of like a sympathy, empathy sort of response to their partner. And then mixed erectile dysfunction is obviously a combination of all of them, because life is never simple and things never go that smoothly. I thought this was a really great statistic that about 30 million men in the United States are affected with erectile dysfunction. And I think that's really significant, that if this is something that there's a lot of social stigma about it. So if it's something that you're having difficulty talking about, or maybe it's hard to bring up with your doctor, it's really still important to do that. You're not alone with it. And it's even more important because the erectile dysfunction is kind of, you can consider it like the canary in the coal mine. It's often our first sign of things like diabetes, cardiac dysfunctions, whether that's a hypertension, high cholesterol, and a variety of other medical concerns. If you think about all of the vessels in the penis are very, very small. I forget what the number was, but they're like a fraction of the size of the vessels that go on in your heart. So if there's something that's causing those vessels to be occluded and have blood flow get to them, you're going to see it in these teeny tiny vessels before you see it in the other ones that help keep you alive in your heart or in your brain. And so this is why it is so, so critical that if you are having any issues with erectile dysfunction, you need to let your provider know. You're not alone. You're one of potentially 30 million men that are having this issue, and it could be a sign of something potentially even more life-threatening. So you got to get that appropriate testing. What do we do for it? And this kind of goes with, I put it after the erectile dysfunction, but this obviously also is, it pertains to with the prostate and after prostatectomies and that sort of thing. Obviously, you can treat it with physical therapy. Otherwise, I wouldn't be the one here talking to you about this. And we'll talk a little bit more about the muscles here in a minute. But think back to all of the muscles that we just talked about that help with ejaculation and help with keeping the blood in the penis and help with keeping you continent. They're still muscles. You can still do physical therapy for them. It just looks a little different. For general health, think back to what we just talked about with the canary in the coal mine, right? There's so many different things. I'm going to try to go back to it. Diabetes, cardiac dysfunction, high cholesterol. How do we manage those? Diet and exercise. Therefore, if they're having an impact on erectile dysfunction, how do we affect it? Diet and exercise. One of my resources suggested foods that are high in antioxidants can be very helpful. From my perspective, weight loss not only is good for you in general, it helps to decrease the demand on your pelvic floor. If you don't have as much mass you have to move around, your body doesn't have to work quite as hard. And exercise, of course, improves blood flow. Stress management, that comes back to that sympathetic nervous system we talked about, right? If you're in fight or flight mode, your body says now is not the time to procreate and have fun. And also there's a lot of education out there and a lot of research on just the impact of stress overall on our body systems. So just that, I think, goes back into that general health recommendation. There's tools that you can use. This is the one that I think my dad was going to watch this presentation. So sorry, Dad. They know what I do, fortunately. So penis pumps actually work on a suction principle to help pull blood into the penis, to help, I think colloquially it's kind of known as to help make things a little bit bigger if that's what you're going for. But because it's working as a suction principle, it's also going to help pull blood into the penis so that you can get that erection a little bit easier. Maybe won't help with the maintaining as much. So you can actually pair it then with a penis ring. And a penis ring, ideally you're going with a silicone one that's kind of stretchy, never go with metal. It's going to kind of create that closure at the base of the penis that's going to help trap the blood in the base of the penis a little bit more. There's also men's vibrators, like the one in the picture here, that is, it goes kind of on the head, the glands of the penis, where most of the nerve endings are, to help with the stimulation, because the more the nerves are stimulated, the more the body's going to react to everything. There are various surgeries out there as well that do implants. I personally have only ever treated one of them. And I think one of my big takeaways was there's a surgery, there's a variety of different implants you can get. They all have pluses and minuses to them that have to be considered. One of the big takeaways I had from the patient I treated was that my understanding is it's typically not a reversible surgery. So if it for some reason is not working out for you, then you might end up in a bigger situation than if you hadn't had the surgery in the first place. So I think that's probably more of a last case scenario, last resort sort of intervention. All right, so this is my bread and butter. What is the pelvic floor? It's made up of 3 different layers. My source for the pictures only had photos of really 2 of the layers. The photo here on, I guess it's our left, sorry, I have to reverse my lefts and rights clinically. This is showing the deepest layer of muscles. So you're actually looking down in the pelvis. These are your muscles that help to support your organs. They also form part of your core muscles. These are the ones that help, like I said, support their stability. They're helping with our posture, and they're actually also helping with our breathing. The photo there on the right that we're looking kind of at the base of the penis and the anus, these are your sphincteric type muscles in general. These are your ones that open and close so that you can maintain your continence, both bowel and bladder. And again, if you look at the base of the penis, we see that bulbospongiosis and ischiocavernosus that are helpful for ejaculation. An example that I always give my patients is to why we need strength and endurance in all the layers is imagine you have a garden hose on the ground. We've got a nice firm floor here where we're doing the presentation. So my garden hose is on the ground. If I'm going to turn off the flow of water in that garden hose, my leg has to have enough strength to stomp on it and turn it off. Now imagine instead of this nice firm ground, we've got a trampoline. It doesn't matter how strong my leg is, I'm never going to be able to shut that flow of water off. So my leg is those sphincteric muscles that are on the outside, and the floor are those deep muscles. The muscles that are deep have to provide enough support so that your muscles on the surface can actually close things off. This is a little bit more of a general overview. Obviously, you know some of the things I can treat because we just talked about it. Urinary incontinence is a big one. I wanted to clarify the different types of urinary incontinence for a second. Stress incontinence, I think, is more often what we think of where I cough, I laugh, I sneeze, I pick something up, I do something, and I have a little bit of urine come out because I applied stress into my system, not mentally, physically. Urge incontinence is going to happen when, I got the urge to go to the bathroom, and that causes a little bit of a leak. Or as I'm going to get to the bathroom, I have a little bit of a leak. Frequency or overactive bladder is another thing that I treat that it has some components from the incontinence where there's usually some physical things going on, but it's also usually there's some behavioral components too. I tell everybody, think of your bladder like a puppy. It's going to do what you train it to do. And if you're always going when it really, really have to go, you're actually going to make that urgency even worse. Bowel is another thing. I think I mentioned at the beginning, these are your muscles of bowel, bladder, and sexual function. Constipation, fecal incontinence, and urge, hemorrhoids are another thing I work with. They're all interconnected. Typically, one of these things is not existing in a vacuum. You're going to have something else going on with it. So even if, maybe you have a history of constipation and it's just that's how I've always been, it can still be a factor that we consider in the incontinence. And then the sexual side of things, the pain. We talked about the erectile dysfunction, arousal dysfunction. Prostatitis, again, is a pain syndrome related to the prostate historically. There's a lot of research going on that, and they're learning more about it. Pain with intercourse. Pain can come from the penis. It can come from the scrotum. It can come from the pelvis. It can come from the muscles that contract and relax to raise or lower your testicles is another really common one. Another thing that's really interesting is that often our pelvic floor can refer pain elsewhere. So if you have a chronic pain in your hip or in your back or in your abdomen that hasn't resolved in a very long time, there's the potential that even though you've had it treated and it hasn't really gone away completely, maybe the pelvic floor is at play if that is something that has not been addressed yet. And I wanted to put this picture on here. This is a podcast. I think it's an episode on someone else's podcast with Dr. Susie Gronsky. She's a pelvic floor physical therapist, and I've done a couple classes that she's done online. She's kind of a really big name as far as men's pelvic floor. It tends to be a niche physical therapy that's primarily focused on women. So I wanted to make sure to put this information out there as a really great source if you're a techie person or you like to listen to podcasts. She's a really great one to look into.
PT stands for what?
Physical therapist.
A physical therapist?
Mm-hmm. Yep. What will we do in physical therapy? If you've done physical therapy for your back or your hip or your neck or your legs of any sort, that gets involved, especially the way I treat. Or pelvic floor dysfunction does not typically exist in a vacuum. I've got a poster in my clinic room that shows all of the muscles that attach to and surround the pelvis. And I think there's like 36 of them. And if there's something wrong with those, you might be getting compensation in your pelvic floor because of those. So we're going to look at a little bit of everything. We're going to look at everything between armpits and knees is what I call it. We're also going to look at the pelvic floor, and we'll talk about that a little bit more in a second. I always tell people, think of all the options as a buffet. You can eat it in any order you want. If you want to start with dessert, you can start with dessert. If you want to do it in the traditional order, you can. If you only want to have dessert and nothing else, that's perfectly fine as well. You might not be getting your money's worth at a buffet. But tell everybody, if you come in and you say, I really don't want to do the pelvic floor assessment, I just am not comfortable with that. We'll talk about that in a minute and you might understand why. That's completely fine. But if you were coming into me with shoulder pain or neck pain, you would want me to look at those two things. And I really can't tell you what's going on with them unless I assess them. And the same thing comes true with the pelvic floor. Unless I assess those muscles, I can't exactly tell you specifically what's going on. I can make some good hypotheses, but you need to see it to know. What is the pelvic floor assessment? Personally, I've never had a prostate exam. Don't have one, so I can't tell you how it compares. I've been told it's not nearly as bad. Tell my women it's not as bad as going to the gynecologist. You are undressed from the waist down. Typically, I treat men laying on their sides. It's just a little bit more comfortable. I think most people don't really like to be laying on their stomach for really long periods, but that is an option as well. We are assessing these muscles rectally. Sorry, gentlemen, that's your only option. We're going to take a look externally as well, because remember, there's those muscles that are on the surface that are really important as far as erection and ejaculation. But those deep muscles that are really important, the ones there on the right that are really important for, left, for your strength and your stability and being able to be upright biped people, those are the only ones that I can only assess those internally. Only one finger. Thankfully for everybody, I don't know if you can see on the computer, I've got pretty small fingers. So we're gonna touch all of the muscles. We're gonna see, I'm looking for pain or tenderness too. If that muscle is really tight, think about when you're really stressed out and your shoulders are really tight and you can't get them to relax, those muscles are gonna be sore. So if part of your problem is that your muscles are actually too tight instead of being too weak, which we didn't talk about, but that is a possibility. I'm gonna create a little bit of tenderness more than likely, or I'm gonna be able to feel that muscle is very tense and tight. If appropriate, now if it's a really tense muscle, we might not do Kegels right away. If the problem is more of weak deconditioned muscles, then we're gonna talk about Kegels. What are Kegels? They are the pelvic floor contraction. They are not only for the ladies. Anybody with a pelvic floor can do it, and I see everybody with their pelvises, assuming everybody online does, you all have a pelvic floor. Now, the lumbopelvic and core assessment is what I mentioned is more like if you were going to physical therapy for neck or back pain or hip pain or leg pain. We're going to look at all of those muscles and see how they function. I really like this picture here on our left because it shows how the pelvic floor integrates with all the muscles of our core. A lot of times we think of our core as being our abdominals, specifically our six-pack muscles. But that's not really true. Our core is a three-dimensional structure that has to act like a highly pressurized system. We've got our diaphragm at the top and our pelvic floor at the bottom that work together as a piston with each other to help with dynamic stability. We've got our multifidi and also our latissimus, if you think of swimmers with their back muscles in the back that help with stability. And we've got our deep abdominals that go down the front, attaching to the bottom of our ribs all the way down to the top of our pelvis. We also have our glutes that are on the back of our hips that are, the ones that give your butt its butt shape. These all play into everything and help to impact things. I also wanted to include a picture of a really common finding that I find with men that is my men and my pregnant ladies typically have what we call a diastasis recti or a diastasis recti, depending on who you're talking to. And that's kind of this coning that you see on this gentleman's abdomen here. That is just where those abdominal muscles, if you think of the split on the six-pack muscles, that starts to come apart a little bit. It doesn't maintain its tension as well. This is a sign that highly pressurized system we were talking about isn't functioning optimally. That's a weak point in the chain. It's like you got a soda can. If you step on the soda can, it's going to stay solid, right? But if I pop the top, I can smash the soda can. So this is your pop top on your soda can. If this is happening, or if you've got maybe back pain, your muscles aren't working adequately, or maybe you hold your breath when you do things, those are all signs that there's something happening in this pressure system. Your pelvic floor might be the thing that is taking over and is trying to produce that stability for you. Leads to problems if it's too tight or it's too weak. So these are just some examples of different treatment techniques. I'm happy to answer questions more about these, but I'm going to kind of run through this a little bit quickly. Manual techniques for releasing tight muscles or other tissues. There's a tissue called fascia in our body that often can be problematic. Exercises for both the pelvic floor and everything else that are focusing both on strength, endurance, and coordination of the pelvic floor and the surrounding muscles. I think also in there you could reasonably add in range of motion of the muscles. If those muscles are tight, they're not very good in any other position. Breathing mechanics is a really big one that we're going to look at. We can use biofeedback. Now, biofeedback is kind of a catch-all term. That can include either me digitally touching the muscles and you squeezing and relaxing if we're talking Kegels. Maybe you're doing exercises in a mirror so that you can see what you're doing. Or we've got a gadget that hooks you up to the computer with some external electrodes, and it gives you a little graph so that you can see what those muscles are doing. That's what people typically know as biofeedback. We're going to correct how you move. I really like to go through posture with people and how you walk so that you can get the most out of that and get the best stability. And then lots and lots of education on your specific issues and how to manage them, because there's a lot of symptoms that go into this. And like I said before, these issues don't exist in a vacuum. There's often some other things that are going into it. Here's your little how-to of how to do a Kegel if you didn't already know how to do that or thought it was just for the ladies. There's a bunch of different things you can think of because there's a lot of different muscles that even though they all work together, they kind of do different things. So you can do a couple different visualizations. You can imagine like you're shortening or you're lifting the base of your penis. Everybody's got a glassy look on their face because they're trying it. You can squeeze like you're trying to stop urine, or like you're trying not to toot in public, or like you're trying not to have a bowel movement. You can squeeze like you're trying to lift your bladder. I feel like that one's a little bit hard to visualize. Or imagine you're walking into a cold pool and everything tightens up a little bit. maybe that one works for you. I teach my patients, these are two-dimensional pictures, so it's a little hard to see, but your pelvis is kind of like a bowl, right? So these muscles are going to sit like a bowl in the bottom of them. When they contract, they lift up when they're nice and strong. So when you're doing those contractions, if you want to imagine those muscles, imagine it like they're actually lifting up. As you're sitting in your seats, you can imagine like you're trying to lift everything up off of the seat. Biggest pet peeve, please don't stop and hurt the flow of your urine. Yes, these are the muscles that do that. It's okay to do it occasionally. Don't make it a habit because you can contribute to other bladder incoordination sort of things. There's a muscle that actually empties your bladder, and your pelvic floor needs to be relaxed for that to happen. If you're constantly contracting pelvic floor when bladder is trying to contract, everything's going to get really confused, and then you're going to be seeing me for urgency issues. How long will PT take? Probably thinking that since I talked so much during this. It depends. This was the first thing they told us in physical therapy school. It's going to be your least favorite, but also the thing you're going to say most to people. It really depends. It depends on if you had surgery, what kind of surgery, what structures were impacted in it, what were your symptoms before surgery if you've already had it, how long had you had them, how severe were they? Those factors that we talked about with the stress and the general health and your overall physical fitness, those are also going to play into things. I have a lot of people that are like, well, I don't really work out or anything, but they're always out walking or they're always out doing things or they're busy at their houses. That all counts. That absolutely all counts. And then the biggest factor is your compliance with your homework. So I'm going to give you homework to do, whether it's reading things or it's doing a bladder log to track your symptoms or it's doing exercises on your own. Those things all make a really huge difference in either getting better clarity of what's going on with your problem or helping to resolve it overall by fixing the issues that are at play. If you're only doing your homework when you come in and see me, or maybe the night before, like me going to the dentist and flossing the night before, then you're not going to get as much out of it. But not going to judge you, not going to guilt you about it because it doesn't have an impact on my pelvic floor. So you do you. I typically see my patients once a week because, again, if you are being compliant with your homework, you're generally getting the most out of it. And I want you, when you come back in, I want us to be trying to constantly progress and move the challenge bar so that you're always getting stronger, you're always getting better. And then the length of the treatment, how many weeks you're coming in, again, that depends on the severity of things. That depends on what all's impacted. That depends on how well you're progressing with the exercises. Some people have a really hard time finding these muscles. Some people get it right away. It all depends. And I would also put, it depends on what else is going on in the body as well. So like we talked about, if your abdominals are a little bit weak, it might take a little bit more time for your pelvic floor to resolve because your body's used to using that to make up for it. How do you get to me? So at TMC, we require a referral for you to come in and see me. Arizona is a direct access state, but we do require a referral. Who can give that to you? Your primary care. Your urologist, your gastroenterologist. We get a lot from pain management because we're right next to the pain management clinic. Pretty much anybody that's a nurse practitioner or a doctor or a PA, physician's assistant, should be able to give you that referral. Just incontinence, constipation, erectile dysfunction, whatever is the issue, those are all perfectly fine things to put on the referral. So I know what we're going to be talking about, or at least what the main issues are. And here's our fax number for you to be able to send it to us. I hope that's big enough on the paper for everybody. Okay, and there's where I got all of my information. I do a lot of, go back. I do a lot of continuing education outside of what I learned in physical therapy school. My PT school was very thorough and had an entire 2 classes in the 3 years I was there. Some schools have none. So I do a lot of additional classes. And then if we're all done with it, the penis book that's by Dr. Spitz, that's over here on the right of the slide. It's a really fantastic book. It's a little bit hard to read. He uses a lot of opportunities to make any and all penis puns he can. But it's a really, really great information if you want something to read about it. Okay. I think we got through it all.
Thank you, Sam. I want to start and just see if were there any questions in the room before I ask.
Yes, we do have
Okay.
at least one. Go ahead.
Yeah, I've got about 6 questions.
He's got about 6 questions.
Okay, well, and just make sure you repeat them back so we can hear them.
Give me one at a time. I don't have a very good memory.
I came to a talk a couple of years ago,
Uh-huh.
and the doctor said that they do prostate surgery through the rectum.
Oh, interesting. So he's asking about prostate surgeries through the rectum. I can't say I have ever seen that. It's right there in proximity, so I don't see why it couldn't be done. One thing that I would have to think about if that were done is how would that impact the bowel side of things, or would it change constipation or fecal continence, that sort of thing. But I don't see why it couldn't be done. I'm just not familiar with it. Yeah.
And I've heard over and over that as people age, their muscles atrophy. We lose a certain percentage of muscle every year above the age of, I don't know, 65 or 60. So does that also apply to the pelvic floor muscle and every muscle in the body?
Yes. So he's asking about as we get older, muscles atrophy and get disuse. Does that also apply to the pelvic floor? 100%. Their muscles, like just like any others, they just tend to be really, really tiny. So they're going to react the same way. But I think with muscles, you really can take a use it or lose it sort of principle. And the more you get started on working on things now, whether it's before surgery or if it's just a prophylactic, I want to have better pelvic health, you're going to help mitigate some of those. There's some MRIs that they have out there of like, I think it's a 78-year-old or maybe 72-year-old. They've done 2 different MRIs. One of them is somebody who's still doing triathlons in their 70s and somebody who's self-described as sedentary. And then I think they also did an MRI of somebody like in their 40s that I think was just like moderate activity. And the person that does triathlon in their 70s, their MRI looks almost identical to the person in their 40s because they're still using their muscles. So the same thing applies to the pelvic floor. Oh, they just did on the leg for that particular one, but it all applies. The more you use it, the less you're going to have that atrophy. There's some other changes that happen as far as elasticity and recovery and that sort of thing, but you're still going to be better overall if you continue to use the muscles.
Okay, and one of your slides, the first ED treatment, it showed people on their back with their legs in the air.
I had that. Hang on, let me look at my pictures. Oh, yes. They're doing the happy baby pose in yoga. So they're laying on their back, holding their feet. That's a really nice stretch for if you've got tight pelvic floor muscles. It's kind of like going into a deep squat. It forces all the muscles to relax and stretch. So that's one I use a lot for people who have a hard time getting their muscles to relax. They're more on the tight side of things because the relaxation component, and I didn't say this in the presentation, but if you take nothing else home, don't start and stop the flow of your urine. And then relaxation is just as important as contraction. Because if you're just constantly contracting like this, you're never getting stronger. Great question. Sorry, he was asking about one of the pictures. That was not Kegels. No, that was happy baby pose. It's a great stretch. And did we cover them all?
Well, and I'm wondering, does the bladder age? Does it get smaller?
Does the bladder shrink with age? I don't know.
It's bigger.
Especially if you can't get the urine out, right? I don't know the answer to that off the top of my head. I would have to look it up. I would assume there's been research done on it, but I'm not entirely sure. One thing I would imagine happens, like we just talked about with age, and one of the things that happens with muscles is that you lose elasticity, and the bladder is a muscle. It's mostly smooth muscle, but it's probably going to lose some of its elasticity and its resiliency. So it might not functionally shrink in size. It just might not be as compliant to hold as much fluid. It might not be able to stretch quite as far.
And how large is the bladder usually? Does it vary?
It varies. You had to ask me that. I always forget the numbers off the top. I have a sticky note in my room on how big the bladder is. I think 800 milliliters is like kind of the middle of the road. Don't quote me on that. Like I said, I always forget the numbers.
Sam, can I ask you a question? We've got a question that came in. having ED, is that an early sign of any kind of prostate health issue?
Is that a sign of any kind of prostate health issue?
What was the question?
Is having erectile dysfunction an early sign of any kind of prostate dysfunction? That's a really great question. I did not see that as I was preparing for this presentation, but it depends. I can see how there could be, if like a cancer were at risk or were a consideration, I could see how that could potentially be a concern. My understanding is it's more of like the vascular and the general health things that it's a sign of.
Okay. And then my other question is, what are some ways that you can injure your pelvic floor?
What are some ways that you can injure your pelvic floor? Well, the simple answers are like falling on a post or falling on your tailbone, or we've all seen those videos of the skateboarder going down the railing and one leg goes one side, the other goes the other side. I think those are the simple answers. I think our friends in the ED could probably tell you some other adventures that they've seen that has injured the pelvic floor that we won't go into in this presentation. But blunt trauma can do it. There's things like anal fissures that you can get where if the anus has a hard time opening to allow a bowel movement, it can kind of split like when your lips are chapped. And that can lead to some injury and dysfunction that way.
To build off car accidents.
Car accidents. I think that's a really great one because those often, especially like the dashboard into the femur, can cause a fracture of the pelvis itself, which obviously impacts the muscles.
Great. Okay. I want to thank you so much for being here.
Thank you.
And we look forward to having you back during Women's Health Month. So thank you for being here.
Everything your mother never told you.
Again, thank you for being here today. We do have another talk coming up on Thursday, and that is what's ringing in my ears and managing tinnitus. So please feel free to join us again on Thursday at 2 p.m. That will be on April 7th, 2 p.m. with Haley Lanou. She is a TMC vestibular audiologist. Thank you for being here.